Welcome to this Clinical Explainer. Let's dive right in. Today, we're taking a really deep dive into the modern management of endometriosis. The clinical landscape for this disease is undergoing a massive, and I mean literally massive, paradigm shift. We're moving away from viewing it as just this acute surgical problem, and instead, we're figuring out how to approach it with a lifelong chronic disease management mindset. So let's look at this whole clinical journey right from the patient's perspective. 8 years. Just let that sink in for a second. That is the jarring reality our patients face. It's the average diagnostic delay from the very first onset of symptoms to getting an official diagnosis. And during that enormous 8-year gap, well, 85% of these patients end up visiting their GP at least 10 times. I mean, imagine the sheer frustration of a patient, let's call her Sarah, who's just enduring nearly a decade of chronic pain, bouncing from specialist to specialist before finally getting an answer. Our main goal today is to figure out exactly how we can close that gap. So here is the clinical roadmap we're exploring today. 1. The diagnostic delay. 2. Clinical presentation. 3. Evaluation and presumptive diagnosis. 4. First-line medical management. 5. Advanced pharmacology. And to wrap things up, 6. Surgery and post-op. All right, let's get into it. Section 1. The 8-year diagnostic delay. So why exactly does this huge gap between symptom onset and diagnosis even happen? The simplest answer? Symptom overlap. Endometriosis doesn't always present like your classic textbook case of dysmenorrhea. Consider a patient like Sarah, who comes in presenting with pain during urination, diarrhea, and chronic fatigue. It's incredibly easy, almost second nature, to misdiagnose that as irritable bowel syndrome or maybe a recurrent UTI. But a major cohort study actually found that endometriosis patients were far more likely to report 5 to 7 very specific visceral symptoms. We're talking abdominal pain, not related to menstruation, pain during urination or defecation, constipation or diarrhea, irregular bleeding, nausea, and chronic fatigue. When you see this specific cluster appearing alongside pelvic pain, endometriosis absolutely must jump straight to the top of your differential. Section 2. Clinical presentation and exam. As clinicians, really listening to the specific characteristics of the patient's pain is absolutely critical. Why? Because the pain actually acts like a topographic map for the underlying anatomy of the lesions. Actually, think of history taking as your clinical detective work. If our patient reports proximal or deep dyspareunia, your clinical suspicion should immediately point toward deeply infiltrating lesions. We're talking maybe on the uterosacral or cardinal ligaments, the pouch of Douglas, or the posterior vaginal fornix. Now contrast that with distal or superficial dyspareunia. That points us toward lesions way closer to the outside, like on the cervix, hymen, perineum, or episiotomy scars. So just by clarifying the exact type of sexual pain, you're already staging the potential anatomy of the disease. It's a real game changer. Now, when we're performing the bimanual and pelvic exam, we're obviously looking for those suggestive findings, right? Focal tenderness, maybe palpable nodules in the posterior fornix, adnexal masses, or finding that the cervix or uterus is immobile or laterally placed. But, and this is an incredibly crucial caveat here, a completely normal physical exam does not exclude endometriosis. In fact, superficial peritoneal disease often yields an entirely unremarkable exam. Bottom line, we cannot dismiss a patient's severe symptoms just because their pelvis feels totally normal to our hands. Section 3. Evaluation and presumptive diagnosis, which brings us to a major shift in how we evaluate this whole disease. Is surgery still the gold standard for diagnosis? For literally decades, we were all taught that diagnostic laparoscopy with histological confirmation was the absolute gold standard. But is it still? Well, the modern clinical consensus is actually pivoting. We're actively moving away from doing immediate invasive procedures just to slap a name on a condition. Let's compare the two approaches. The emerging standard of care right now heavily favors a presumptive clinical diagnosis. Relying on ultrasound, MRI, and the patient's symptoms allows us to start empiric treatment right away. It's lower risk, it completely avoids treatment delay, and honestly, it just gets the patient relief faster. Now, definitive surgical diagnosis remains the traditional gold standard. Yes, it provides that tissue biopsy and allows for concurrent treatment, but it is invasive and it obviously carries surgical risks. So today, we really reserve surgical diagnosis for patients with severe symptoms, those failing low-risk therapies, or when we absolutely have to exclude malignancy. The big takeaway? Start with presumption, start with treatment. Section 4. First-line medical management. So once you've made that presumptive diagnosis, how do we actually manage the pain? Well, this should be your immediate low-risk go-to algorithm. Step 1, initiate a trial of NSAIDs plus combined hormonal contraceptives. And by the way, continuous dosing is usually preferred here to avoid that withdrawal bleeding. Step 2 is where it's absolutely critical. Reassess those symptoms at 3 to 4 months. Please don't just hand a patient a prescription and tell them to come back in a year. If they have only partial improvement or no improvement at all, we move right to Step 3 and escalate to GnRH analogs.
Section 5. Advanced Pharmacologic Treatment Options.
Let's look at exactly what to do when those first-line therapies fail, and we need to build out our options. Enter the GnRH antagonists, like elagolix and relugolix. These are literal game changers. Unlike the older GnRH agonists that required injections and usually cause this horrible initial symptom flare, antagonists are oral medications. They competitively bind to receptors without actually triggering a response. This rapidly suppresses the pituitary gonadotropin hormone production to create a dose-dependent hypoestrogenic state. Basically, we are starving the endometriotic lesions of the exact estrogen we need to grow. And the data backs it up. In clinical trials, up to 75% of patients reported clinically meaningful reductions in dysmenorrhea while on these drugs. But as you might guess, creating a hypoestrogenic state comes with a massive caveat: menopausal symptoms. And this is where add-back therapy comes into play. When you're prescribing long-term GnRH analogs, you absolutely must use concurrent administration of hormones, like norethindrone acetate. Think of this add-back therapy as a protective shield for your patient. It minimizes those brutal hypoestrogenic side effects like severe hot flashes, and, crucially, it protects their bone mineral density from irreversible loss. So we're suppressing the disease with the antagonist, but protecting the patient's quality of life with the add-back. Section 6. Surgical Intervention and Post-Op. Of course, medical management does have its limits. So when exactly do we operate? Well, surgery is indicated in some very specific clinical scenarios. When there's persistent pain despite maximized medical therapy, if there are contraindications to or the patient just flat out refuses medical therapy, if we need a tissue diagnosis, or if we have to exclude malignancy in an adnexal mass. And obviously, on a much more urgent note, if there is an obstruction of the bowel or urinary tract from deep infiltrating lesions, surgery is an absolute necessity. Now, when we look at the statistics on reoperation, it drastically changes how we need to counsel our patients. Check this out. Conservative surgery, which excises or ablates lesions to preserve fertility, is associated with a staggering 58% repeat surgery rate over 7 years. 58%! It's highly effective in the short term, but the disease very often comes back. On the flip side, definitive surgery, meaning a hysterectomy with or without oophorectomy, drops that reoperation rate down to 19%. And if both ovaries are removed, it plummets all the way down to 8%. We have to present these realities clearly so our patients can make fully informed shared decisions that balance their pain, their fertility desires, and their tolerance for future procedures. Looking at the evidence-based surgical best practices, there are a few things to keep in mind. First, excision is generally preferred over ablation, especially for deep lesions, just to make sure you're getting clear margins. Second, adhesiolysis should be performed selectively to avoid injuring vital structures. Basically, only lyse what is actually causing pain or infertility. Also, we need to clear up a common misconception. Preoperative medical suppression is not recommended simply to improve surgical outcomes. It just doesn't help. And finally, keep in mind that a hysterectomy without oophorectomy still risks triggering early menopause, usually 1 to 4 years earlier due to the disrupted blood supply. I really want to anchor our entire discussion on this specific quote from the American Society for Reproductive Medicine. They state, "Endometriosis should be viewed as a chronic disease that requires a lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. In short, surgery is a tool. It is not a cure." And that exact philosophy means post-operative medical suppression is absolutely vital. We literally cannot perform a flawless, beautiful excision and then just send the patient home on nothing. To actually break the cycle of symptom relapse, we must utilize NSAIDs, hormonal contraceptives, or LNG IUDs for anywhere from 6 to 24 months or even more post-op. It prevents the symptom relapse and it actively protects our surgical success. Which leaves us with this final, really critical question. How will you shift your clinical mindset from acute surgical fixes to lifelong disease management to close that 8-year diagnostic gap? Are we going to start trusting presumptive clinical diagnoses more? Are we going to actively look for those non-pelvic symptoms? By transitioning to this idea of lifelong disease management, we hold the power to permanently close that devastating diagnostic gap for patients like Sarah. Thank you so much for joining me on this explainer, and I'll catch you in the next one.